will be by Professor Fran Baum. Now, Fran is the Matthew Flinders Distinguished Professor of Public Health and Foundation Director of the Southgate Institute for Health, Society and Equity at Flinders University. Fran is one of Australia's leading researchers on the social and economic determinants of health, and from 2009 to 2014, she held a prestigious Australian Research Council Federation Fellowship. She is a member and past chair of the Global Steering Council of the People's Health Movement, a global network of health activists, and she also served as Commissioner on the World Health Organisation's Commission on the Social Determinants of Health from 2005 to 2008. Please welcome Fran, who will present on the National Health and Medical Research Council's evaluation of the South Australian Health in All policies, a particular collaborative policy. So thank you very much and welcome, Fran.
Well, good morning, everybody. It's great to be here, and I'd also like to acknowledge that we're meeting on the lands of the Kaurna people and pay my respects to their elders past and present. What I'm going to talk today is drawing on a piece of research that we've done funded by the National Health and Medical Research Council. I think I need both of these. And drawing from that data, thinking about, well, what creates the conditions for what I've called integrated policy action. And my focus is health. I come from a public health background, and for me, Ian mentioned that I served for 3 years as a commissioner on a WHO commission on the social determinants of health. And one of our major conclusions was that the degree of health equity in any society is a great measure of how well it's doing. So, and one that can be put alongside economic performance. So my comments are very much framed by that. What we're trying to do, why do we want to break down silos? Why would we want to do that? And it seems to me that we have social factors, environmental factors and economic factors that broadly shape most of the things we do. The aim is to bring those together, not entirely overlap them. As Susan Close reminded us this morning, there are benefits of within sector activity, but we want to aim, and I think there are two key aims. One for me is health and equity, because I think they're great measures of how we're doing. And the other one is sustainability. And, while as we are here in Paris, the future of the planet is being discussed. So clearly that's an absolutely vital thing. It also strikes me in public health, one of our dictums is, of course, that prevention is preferable to cure, and that's the basis of our discipline. And it seems to me that a lot of joined-up action, a lot of whether it's health in all policies or any other, is about trying to prevent things before they happen. And that's always a hard task anyway. I mean, it's better to prevent a bushfire than to deal with it. It's better to prevent a disease than have people in hospital, partly because it's cheaper, but also because it's better for people. So if you look in most sectors, there will be an area that's about whether it's crime prevention, early intervention, or health promotion. But usually, if you look at that area in the sector, it's underfunded, it's not well regarded. So if you look at the health sector, in South Australia, we've actually withdrawn a whole lot of resources for prevention, and we've put all our eggs in the basket of the hospital sector. Now, from a public health perspective, that doesn't make sense. But, you can see why people do that, because if something goes wrong in a hospital and there's ambulances ramping, that's what people want, that's what they clamour for. You don't see people on the street saying, I want more prevention, bring us prevention now. And yet, that's the real challenge for government, I think. Now, the other thing about wanting integrated holistic solutions, as long as I've worked in public health, people have been calling for that. And if you look back over the decades, it's a bit of a holy grail, really, of public sector administration. Here I've just put some examples, particularly drawing on health, but you think UK joined up government, we've had health action zones in the UK, the EU started the health in all policies, the WHO had an Ottawa Charter in 1986 which called for that, and so on. Whichever sector we look in, you will see these calls for joined up government. I think there are lots of examples of one-off successes of joined-up government, but not very many of systematic approaches across government. In fact, I don't know if we could point to any. The commission that I worked on concluded two things: that health was determined not by health sector. Health sectors are important, but maybe up to 20% of health improvement. The rest comes from improvement in education, housing, urban environment, social inclusion, and critically from the way we distribute power, money and resources. So for instance, if we're a more equal society, you're likely to be healthier. And we had a basic logic on that commission, which I think should drive a lot of joined-up government, of why would you want to treat people's illnesses, addictions, or send them to jail, but then send them back to the conditions that created that. And it's joined-up government that's going to prevent those conditions creating us as a society having to provide more hospitals, more jails, and more ways of treating people with a variety of addictions. Some work done at the University of Canberra estimated, well, if we don't act on these social determinants of health and well-being, then how much will that cost us? So they thought we could save 2.3 billion in avoidable hospital costs, we could cut a lot from the pharmaceutical benefits scheme, and we could save $4 billion in welfare payments. That was just a crude estimation, but it gives you some idea of the value of investing in prevention. And I think there's also great benefits in terms of simply people being healthier. And that's good for employers, that's good for education, it's good for social interaction, it's good for parenting. So everything you can think of works better if people are healthy. Promoting health is also very compatible with low carbon and sustainable futures. And clearly we now recognise that we're at a stage on our planet, if we don't secure the planet, then nobody's going to have much health. Driving here, I was listening to the presidents of the Pacific Island nations, whose very livelihood is completely threatened by what's happening with global warming. There are many economic benefits. It's not hard to see those. I've already pointed to some of those. And in South Australia, of course, when Health in All policy started, John Hill used to love showing this slide. How many people saw John presenting this? Where he pointed out that if we carry on in the same trajectory, healthcare will take all your budgets. All we'll be funding at the state level is health, and nobody else will have a budget. So Health in All policies, well, Health in All policies is not just about joined-up government, but it's also about saying, well, other sectors should take into account in a systematic way the health and health systems implications of their decisions and should avoid harmful impacts. And it's really founded on health-related rights and obligations, that health is a human right. And it emphasises the consequences of all sectors, of what they do, having an impact on health. And it really aims to improve the accountability of policymakers for health impacts. So it's interesting that the Minister this morning talked about the accountability within silos. This is about the accountability across silos. So Health in All policies has really been operating in South Australia since 2010. We've worked very closely with Karma Williams in the front, who's been the, pardon? 2007, sorry, when we had the conference, yeah. Well, the initial, I guess the first document was 2007. We've worked very closely with Karma Williams, who's been the manager of the Health in All Policies team, and we were successful in getting funding from the National Health and Medical Research Council with a big team of people who are both policy players and academics. I won't go through everybody, but you can see that it's been quite a challenging project to manage. The enablers and barriers then, this is based on, we've had a very mixed methods research approach, which has included in-depth interviews and surveys, and we're now 4 years into the project. And the key factors I want to talk to you today are about having a preventive focus, having a dedicated unit, having a central consistent mandate, aligning goals, providing resources, and having some participatory mechanisms. All those things seem to help this Health in All policies joined-up government approach. Now, in South Australia, we've had a long history of preventive action. In the 1980s, way ahead of the rest of the world, we had a social health policy. I think we've probably forgotten that now, but we did have that long history. We've had healthy cities projects. People may have heard of the Noarlunga, Onkaparinga healthy cities. We've had the obesity prevention and lifestyle, and of course a big history of tobacco reduction. We also had a Thinker in Residence programme. We've recently published a paper about that, which in fact is one of the only papers that we found in the academic literature about our Thinker in Residence programme. And it's very clear that Mike Rand saw that programme as a way of breaking down silos. And our assessment of it is that it did it very well. I think it was a great programme. And in South Australia now, we also have prevention through a public health division that does some great work. I think they're strong in terms of the work they do, but not in terms of their numbers if you compare it to the hospital sector. And we have a Public Health Act that calls for this kind of joined-up action to promote health. We've also discovered that a dedicated unit is really important because it provides a core of staff who have the time, authorisation and skills to do collaborative work. That's their job. And that really helps to build and foster the trust. And trust is really the oil that makes collaboration work. That's kind of obvious, because if you don't trust someone, you're not going to work with them. But it is very important that that is built. So here's an example of just saying that the unit does the propelling forward. And this one's very interesting. I think this public servant said, you need shepherding, someone to keep everyone on board and on track. And I think that shepherding function is really important. And I think someone else said, well, I don't think anything of this would have happened unless there was a dedicated unit and the resources to go with it. And they're just saying that it's the people in the unit that really made that happen. So that's one thing, a dedicated unit. Another crucial point is having a central mandate, and Health in All Policies, while it had the catalyst from the health sector, had the mandate of Premier and Cabinet. And that was really important policy driver, and it really supported Health in All Policy as a pool of resources that could be accessed across government. And one of the things I think this person said in favour of participating in the project was the fact it was reporting up to a body that I thought would have some influence for change. And at that point, I think that was the senior management group. So that was really crucial. But what gets in the way, and I guess this is another way of saying what cements the silos rather than breaks them down, well, people have pointed to fragmented strategic planning, which makes it difficult for them to identify where the government is going and to align their work with it. So when Health in All Policies started back in 2007, thank you, Carmel, the SASP, the State Strategic Plan, was really seen as a guiding light that kind of it was part of the authorising environment. And people are saying, well, since then we've had to adapt to 7 strategic priorities and then 10 economic priorities. So people are finding that a bit of a flux. It's less clear than it was at the beginning of the project. At the beginning of the project, people were clear. Also, I think people feel that therefore they need to continually realign the implementation work with the new drivers, and that seems to be leading to a much more reactive approach. So if you think about the importance of prevention, the new drivers are more about reaction. And reactive policy, according to Robinson, writing in 2014, is intended to remedy problems that already exist, often at the point of crisis. This conflicts with well-established long-term strategies to promote health and well-being. And I think there's a danger that in the last few years we've moved more into that reactive space as different strategies have come, as there have been more economic challenges. And an example here is from a public servant that we interviewed this year from a sector other than health, saying, in my department we're doing reactive policy work. That's entirely different to proactive policy development. The point that I can't make strongly enough is that the current environment is very fast-paced. The idea that there would be resources available to go back to the beginning and have a different look at the way things emerge, I think, it's a failure to understand the relationship between the politics and the policy in the current context. So people really feeling they can't reflect, there's too much turning, and I can see lots of nods going on, so I presume that's captured a feeling in the room. All right, then another really important thing is about aligning goals. And this, in fact, I think relates to the first point about the unit, that I think one of the great benefits of the Health in All Policies approach in South Australia was that they didn't come in and say, you have to do what we want in health. They came in and said, is there some common ground there? Can we align the goals? And certainly our data suggests that was really important, that people that they felt that the health players came in without great assumptions, but always looked at what would be the basis for collaboration, and that was really important. justifying intersectoral alignment can also be complicated by, we found, siloed and narrow structures of accountability and performance across government. And some British researchers, including Michael Marmot, who chaired the commission that I served on, pointed out that bureaucrats and ministers are generally not rewarded for pursuing cross-government initiatives, as governments compete for resources, avoiding cross-departmental activities. So avoiding those activities presents an opportunity to defend territory, and we certainly found that that's true. And I'll just skip through that one. The other issue that has come up particularly, I think in our actually in the interviews really in the last 3 years, is that people perceive some politically driven resourcing. And so, not surprisingly, people reflect on the importance of having enough resources to do a project, whether that's funding or skilled staff. But they also reflected about the political forces behind that resource allocation and felt that intersectoral work to promote health and achieve long-term improvement is often frustrated by what they perceive as politically driven, narrow focus on diverting resources to strategies that they see will achieve short-term popularity and political gains. And perhaps people don't always want to recognise this, but it seems pretty common. This has been noted in the literature as policy myopia or short-termness, where politicians divert resources into activities that yield short-term results, which will be realised while they're still in office, rather than taking that long-term preventive approach. And people there talked about ribbons to cut and so on. And then finally, in terms of resourcing, frequent restructuring of government in response to political changes in order to demonstrate, this is a quote, a new political way forward, focuses attention on department structures and survival rather than links. So people are bothered about what's happening, what are the changes, how are we going to cope with those, rather than looking outside the silos to what they might do. And this is just a quote where somebody says, there's no doubt the more reorganisation you do, the less productive people are. You're always rushing around, being very busy, thinking you're doing something, but actually all you're doing is just reorganising. So people found that quite frustration. And the other thing is that I think people also are expressing concerns about the idea that if we mainstream an idea like health in all policies, does that really work or does it get lost? And the second quote there, you've got to be very opportunistic, but you still have to have a sustained effort on something. And people saying, well, it really needs to be embedded in the system before you withdraw dedicated resources, because if you don't have a systems approach, then it's not going to go. And then finally, all the literature really on policy change suggests that this nutcracker effect is the most effective when you have the top-down, bottom-up, and that requires a lot of resources. And while we recognise that SAS did have a good consultative base, the health in all policies approach didn't have a whole lot of resources to do that kind of participation, and very often departments didn't. And I think Ruth's already talked about some of the pressures that might cause that. So the factors, I think, that encourage a preventive integrated approach are this focus on prevention, the mandate, organisational stability, the dedicated catalyst unit, aligning goals so that there are rewards for collaboration is really important, avoiding policy myopia, and having effective participatory mechanisms. Thank you very much.